Good afternoon, members of the Pharmaceutical Society of Kenya. Good afternoon, our panelists for today. Good afternoon, our speaker. Good evening, our speaker, Dr. Sigilai. Good evening, Dr. Lee. Good evening, Lily and Dr. Eric Muringu. Our esteemed attendees and our esteemed members of the profession, beginning with the senior members of the profession joining us. Welcome to today's webinar on glucose monitoring. Our webinar speaker for today, our speaker for today is none other than Dr. William Sigilai. He is a physician and diabetologist at Kenyatta National Hospital. This webinar begins at 7 o'clock. It's now 7:04. We give an allowance till 7:10 to allow members to be able to join in. Today, Dr. Eric Muringu is going to take us through the first part. I'll come in to probably introduce and probably in the conclusion part. So ladies and gentlemen, kindly feel free to add your questions on the Q&A. Add your questions at the Q&A. Please remember to put your questions at the Q&A, and also remember that this webinar is brought to you courtesy of Roche Diagnostics. Roche Diagnostics are the sponsors for today's webinar. So without further much ado, ladies and gentlemen, let's probably, as it's 7:04 and there are only 200 of us in, let's be kind to our brothers. Let me know where you're joining us from so that we at least understand and our speaker understands the various audience that are with us today. Kindly on the chat box, let me know where you are from and which probably you can mention the PSK branch and probably you can say which pharmacy level do you practice. Are you at the community? Are you at the community level? Are you at the hospital level? Are you a consultant? Kindly just drop that on the chat box as we continue. Karibuni nyote kwa somo letu la leo. Asante. As we wait for members, we begin officially at 7:05. In the meantime, kindly drop down on the chat box and let me know where you're joining us from. Dr. Neto, clinical pharmacist from Jaramogi Hospital. Dr. Gedenji, PSK Nairobi branch. Asante sana daktari. And an MTM practitioner. Karibu sana daktari. Dr. Dorothy Ayuak, KNH Hospital. KNH, that is asante sana daktari. Probably Dr. Sigilai is smiling because he's seeing his colleagues wake wameingia kumjoin today's webinar. Dr. Wanjiko Jane from Karen Hospital, welcome. Dr. Mutiga Martin from Defense Forces Memorial, karibu sana. Perfect. Joyce Mbidi from Roche, you're also welcome. Dr. Matimbai, the chairman for Kakamega Western Branch, karibu sana daktari. I can see your members from Western, Dr. Lydia Kalai is also with us here. Dr. Irene Weru, asante sana daktari for joining us. So ladies and gentlemen, we begin officially at 7:10 and Dr. Eric Muringu is going to be moderating for us. So mine is just to welcome you and probably ensure that we are up to par the numbers that we expected. Dr. Jitesh Dodia, that is from Meru, karibu sana daktari. You're reminded that the webinar is on the PPB portal, so ensure that you subscribe onto the webinar. And let's put all our questions on the Q&A tab for ease of operation. Dr. Duncan Jao from Nanyuki, karibu sana daktari. So we are left with 3 minutes. Exactly 7:10, I'll share our first poll. After that, which I will welcome Dr. Eric Muringu to take us through. Dr. Eric Mwangi from KUTRH, Dr. Njao, karibu sana. Dr. Paresh, Hari Nakuru, asante. So we're left with 2 minutes, ladies and gentlemen. Just keep us engaged on the chat box, and remember to ask all your questions on the Q&A tab. They shall be responded to. Dr. Josephine Nguri, karibu sana Mutuini Hospital and PSK Nairobi branch. Once again, ladies and gentlemen, esteemed members of the Pharmaceutical Society of Kenya, seniors in the profession, today I can see the chairperson for Western PSK branch, Dr. George Matimbai is with us, senior members at the National Referral Hospital, that is Kenyatta National Hospital, Dr. Irene Leren, Dr. Dorothy Yuak, other members of the profession from wherever you are joining us from in the nation, our pharmtechs who have joined us today, our speaker and our sponsors. Once again, allow me to acknowledge your presence and receive our greetings, the greetings from the PSK National Executive Council, led by none other than the President, Dr. Louis Mashogu, and also the Secretariat, Dr. Daniela Munene. Welcome to today's webinar. Today's webinar is on glucose monitoring. And the speaker is none other than Dr. William Sigilai. He's going to begin in a few. Before that, it's already 7:10 and as I promised. So I'm sharing with you a poll for you to be able to see. We are having a poll with 6 questions, ladies and gentlemen. Kindly on the I hope you're able to see the poll. Are you able to see the poll? Perfectly in order. I'm launching the poll. Ensure that you vote and participate in the poll. The first question we're having for today is AccuCheck Instant Meets there. It's a multiple choice question. You have options to answer there. This is a webinar in collaboration with Roche Diabetes Care. That is why the poll question is tailor-made for Roche Diabetes Care. So ladies and gentlemen, I'm waiting for you to be able to vote in the poll so that we are able to go ahead with the webinar. Dr. Eric Murigo, can you see the poll from your end?
Yes, I can, Bao.
It's perfectly in order. Perfectly in order. So we give them 3 minutes for them to vote. Perfect. To give 3 minutes till 7:15, we begin. As they go ahead, Dr. Eric Muringu. Hello, Dr. Eric.
Thank you, Mbao. Thank you, Mbao.
Take over.
Thank you for the opportunity. I see the polls are still streaming in, 66 of 335. I don't know why people are not voting immediately. I'm aware that KMPD elections were held today, and I want to believe that we are all techno-savvy. Kindly participate and enrich this discussion. My name is Eric, National CPD Coordinator, and I'd like to stress what Mbao said as you continue to vote, that the moment we have this event, kindly ensure you log on to the PPB portal, subscribe to the event. These events are now appearing for a maximum of 1 week. So if you don't subscribe during that 1 week, you won't find it. And then after that 1 week, I'll send a token. Then you'll say the event is not there, but you had 1 week to subscribe. So ensure that when the event happens, you immediately subscribe, because if you don't, the token that I'll send may not help you. So thank you very much. I want to believe we are all voting. We are now at 108. Our speaker today is Dr. William Sigilai, a physician and diabetologist at KNH. Thank you, Sana Daktari, for honoring and gracing this event, the CME. We expect to learn more and to be better practitioners where we are. Remember, as usual, everyone is muted, but question and answer tab is very active. Kindly ensure that you ask your question as the CME continues, and the token will be sent to you. And make sure, most of all, ensure that you subscribe. So I don't want to stay much on this. Still, we don't even have voter turnout. I'm urging everyone to vote now. I don't want to end and close people out. Kindly vote before I close it. So even as you do that, maybe now we can allow Daktari to share his screen. Yes, Dr. Sigilai, you can share your screen. So that when we end the poll, we invite you to talk. Once Daktari is finished with speaking, we'll have Lily Wanjiku presenting. Then we'll have question and answer. Most of the questions will come from what you've typed on the Q&A. So kindly make sure if you have a question, put it there, then we'll handle QA. We expect to be finished before 8:30. We don't want to keep you past a minute past that time. So we'll be right on time. Lily, allow me to end this poll kindly and then invite Dr. Sigilai to take over. I believe we have a feel of what is on. Thank you so much, Daktari. The floor is yours.
Thank you very much, Dr. Eric. And just 1 minute. You can see my screen, I believe.
Yes, I can. It's clear.
Okay. So members of the PSK, good evening, and it gives me great pleasure to share this talk with you tonight. I thank Roche for inviting me. This is, we are talking about diabetes with a specific focus on glucose monitoring and how we utilize that aspect of diabetes management. I'll be very specific in my talk, and there are just two major aspects of this talk. One is the overview of diabetes in general. I think we need to acquaint ourselves with the global and local situation with respect to diabetes and what it does to the impact on our healthcare system. Secondly, we will have that aspect of the evolution and the current status of blood glucose monitoring. And the Roche, our Roche sponsors will be able to guide us through some of their systems that are in place. So the agenda is as displayed, ladies and gentlemen, and we want to look at the challenges in managing diabetes and an overview of SMBG, which is self-monitoring of blood glucose, structured testing and pattern management, and then finally the care tools to enable meaningful testing. So we are all aware of the fact that diabetes is a global threat. It is a threat to health and to healthcare systems. it is a much, much greater healthcare threat even than COVID. It's been with us for centuries, and we have made no progress, no great progress in halting its march. Here, this slide is a global atlas that shows is a global atlas that shows the distribution of diabetes globally. You can see the different colors for the entire globe. I think you can see there that Africa has an estimated 19 million people with diabetes as of this 2 years ago. Estimated to rise to 29 in 2030, and by 2045, we will have reached 47 million people, and that is more than 100% increase over the next just over 20 years. You can see, ladies and gentlemen, that the current global situation is that there's an estimated number of 463 million people suffering or living with diabetes across the globe, and about 51% increase globally is expected by the year 2045, bringing the number to 700. And this is among patients in the age group of 20 to 79 years. Of special attention is the color. This purple color represents parts of the world where diabetes, the increase in numbers will be highest. And you can see the rest of the world: North America, green, blue, sky blue, light blue. Those areas represent the rates of increase, which has been highlighted here. That especially in Africa, by 2045, there's an expected 143% increase from the current numbers. And unless we do something between now and then, this increase will be unrelenting and will have a major impact on our healthcare systems and on the health of our population. You can see the next region of the world with the worrying increase or expected worrying increase is in the Middle East. North Africa and the Middle East, basically Arab countries. That also includes the Gulf region, that is Kuwait and Saudi Arabia and UAE. The number of increase is equally worrying. So this is a hotspot of expected diabetes, rapid increase over the next 2 decades or so. These other parts of the world are starting to experience decline. You can see Europe has the best control mechanisms in place as we speak now. Only an expected increase of 15%, followed by, I think, Oceania at 31%. South America, which still shares a good number of challenges with Africa, 55%, and then North America, 33% increase over the next 2 decades or so. So gentlemen, ladies and gentlemen, here we are looking at the link between hemoglobin A1C and the hemoglobin A1C, which is a glycosylated hemoglobin, is a time-honored mechanism of monitoring a long-term blood sugar control. It generally tells us what has been happening over the previous 3 months, and all the major studies have confirmed that even a modest or simply a 1% improvement over the current hemoglobin A1C can reduce long-term diabetes complications by the margins that are highlighted here. Remember, we manage diabetes basically to prevent morbidity and mortality. And the mortality and the morbidities that we are talking about are myocardial infarction, death microvascular complications, amputation, or death from peripheral vascular disease. Now you can see the biggest impact of improved blood sugar control by means of a 1% drop of HbA1c has a 43% risk reduction. This is to say that if a patient has a 10%, if the patient's current HbA1c is 10% and you lower that 10% to 9% through various interventions that include treatment and lifestyle change and so forth, you have actually reduced that person's risk of these complications by these margins. And that is very impressive. And it will surprise you that this is apparently very difficult because of the complexities in managing blood sugar control. So hemoglobin A1c is a very important tool. It is a very basic laboratory test, which sadly is not available in the majority of counties. And colleagues who are logged in here, I know your practice is in the pharmaceutical area of the hospital, but if you ask tomorrow your laboratory colleagues if we're actually offering hemoglobin A1c, you will be surprised that this is not available, and yet we're expecting to make an impact on the diabetes care. So it is very basic, but extremely important. Again here, ladies and gentlemen, we have targets for glucose control. So we manage diabetes with targets in mind. And these targets in mind have been agreed upon by all the leading global diabetes authorities. ADA is the American Diabetes Association. AACE is the American Association of Clinical Endocrinologists. And then International Diabetes Federation. So they have set the targets for good control, HbA1c, in this manner: ADA 7% or less, AACE and ACE less than 6.5, IDF less than 7%. We actually apply the same targets in this country. Our guidelines are based on this, even though we also have our national guidelines for diabetes management. We've borrowed heavily from the global practice. We also use fasting blood sugar, otherwise known as preprandial glucose, in these ranges to signify good control or to denote good control. And ADA's targets 4.4 to 7.2 as a good control, as good fasting blood sugar, and AACE 6.0 or less, IDF 6.0 or less. And then 2 hours after a meal, what we call postprandial blood glucose. The target is below 10 for 2 of the guidelines, ADA and IDF, and less than 7.8%. You notice there are some slight differences between regions of the world based on their experiences and based on the resources available to them for the achievement of those goals. And generally speaking, less than 2.8 millimole above the fasting or preprandial blood sugar is a reasonable goal when trying to reduce postprandial excursions. We'll talk about what excursions mean after meals. Here we have, we are looking at the two aspects of which I've just referred to. The difference between postprandial hyperglycemia or post-meal blood sugar and fasting blood sugar, and the relationship with HbA1c. The biggest contributor of HbA1c on average is fasting blood sugar. But as we get closer and closer to the target of 7, or in this region of 7.3 to 8.4, the role of fast or postprandial blood sugar becomes prominent. So we will, when you have fixed the fasting blood sugar challenge, now you work on postprandial hyperglycemia, because postprandial hyperglycemia can become a major hindrance to your achievement of the targets. And that is when we choose the therapies that are able to target postprandial hyperglycemia. The various therapies that are available there actually have different properties. Some are good at lowering the fasting blood sugar, and others have postprandial hyperglycemia. And this is what the clinician should focus on. Then I've skipped one slide. So postprandial glucose and glycemic variability. There's an aspect of diabetes, of blood sugar management referred to as variability, which was previously which received inadequate attention in the past. That means you may have what looks like well-controlled sugar, but the level of variability will affect or will put the patient at risk of complications. So studies have revealed or have come up with evidence between the association between postprandial hyperglycemia and cardiovascular risk. So postprandial hyperglycemia is actually a risk factor for heart disease. And there's evidence to support an underlying link between this and oxidative stress. And oxidative stress has been held responsible for the underlying cause of macro and microvascular complications linked with type 2 diabetes. The complications that we will witness in the small vessels of the body, like in the eye, the kidneys, and then the heart, the brain, and the circulation to the lower limbs. And glucose variability exhibits a more specific effect on oxidative stress than persistent hyperglycemia. So there's a big difference between a person who has persistently high blood sugar, which is quite bad, and then one who seems to swing from, for example, here, 12 on one occasion, and then even below 4 on another occasion. This has a lot of stress. This induces a lot of risk to the cardiovascular system. These are two examples of two graphs showing similar hemoglobin A1C levels. On the left, on my left, 7.8%, and on the right, 7.8%. But if you look at the graphs, they are totally different. The first one has a less wide variability, between 6 and about 11. And then on the right, we have a very much wider variability, between about 3 and 12. And this is repetitive. Now, this has been associated with bad outcomes. And that is where modern testing tools have enabled us to pick out this variability and address these issues with the patient, with a view to achieving a less variable glycemic pattern, which will confer upon the patient the benefit of less macrovascular and microvascular complications. Now, effective use of diagnostics within the consultation, HbA1c, and self-monitoring of blood glucose. Now, colleagues, I think you know in the various places where you practice, the majority of us on this forum, I believe, and I think you're serving across the country, with the exception of those who serve in a good number of private hospitals in this city and others, testing is still like a luxury, and clinics are still being run. Diabetic clinics are being run in the country based on a single blood test that is done on the day of the clinic and nothing else. And it is very frustrating to the practitioners, the team that cares for diabetic patients, the doctor, the nurse educator, the nutritionist, and even the pharmacist who is involved in the tail end of the provision of the medication to be used. We are managing patients without the benefit of adequate testing, and the A1C has been made to look like it's luxury, as I have referred to earlier. So whereas A1C is a good indicator of overall long-term exposure to blood sugar control, isolated use does not provide the clinician or the patient with enough information to assess the current glycemic control status. I think I have clarified that point. It is just a summary of what the patient has experienced over the last 3 months. and doesn't tell you what was happening in between. It does not tell you what happened in the last 24 hours and so forth. And only self-testing, when a patient has a meter and is able to chart their finger prick results and share with the healthcare provider, can this testing be useful. So as you can see, A1C does not identify variability, and it does not peak the frequency of hypoglycemic events, which is a barrier in achieving glycemic targets when we are managing diabetes. The most scary thing about managing diabetes is development of hypoglycemia, and it drives the patient towards less and less stringent blood sugar control because of the discomfort, the fear, and the risk that it poses. Now, the A1C does not tell you that over the last 3 months, this patient has experienced how many hypoglycemic episodes. It doesn't either tell you whether there have been any postprandial hyperglycemic episodes, and it doesn't tell you what is the cause of this variability. So that is the weakness of HbA1c, even though it has its benefit. Now, the benefits are here of SMBG, self-monitoring of blood glucose, for both the patients and the healthcare team. So according to the IDF, this has been charted to show you where SMBG sits in the middle of these activities. It is central to the diabetes education and understanding, assessment of blood sugar, optimization of therapy, and behavioral assessment. And on both sides, on either side, we have now the patients we are serving and the healthcare team. So you can see the preeminent role of the SMBG, which helps these teams to understand what is going on. So the benefits of SMBG to healthcare professionals, on the one side, with respect to glycemic assessment, is it enables patients and healthcare providers to identify the excursions that I have mentioned about the degree of swings of the blood sugar between the lowest and the highest, and the frequency, and as well as occurrence of hypoglycemia, very important. It enables the healthcare providers to assess the overall glycemic status. Used well and over a significant period of time, you will be able to pick the pattern. And then optimization of therapy, which is very important. When the healthcare provider views the patient's log of blood sugar readings, they are able to adjust the therapy with respect to what you can see. Are you adjusting the therapy to fix fasting hyperglycemia, or to fix postprandial hyperglycemia, or to address the aspect of hypoglycemia? So it provides information about treatment adherence. It may actually reveal to you that the patient is not adherent to the treatment that has been so painstakingly prescribed. The other benefits of SMBG one is to it helps the patient to gain understanding of their disease, and highlights also the effects of the various foods, various physical activities, medication, stress, and illness on their blood sugar. Some patients will tell you that when I exercise, I have noticed that this is what happens to my sugar. And when I eat nduma or ugali or white bread, or even take honey, because there are many stories out there about what you can take, this is what I noticed. So the keen patient will be able to understand this. Then shows the relationship between insulin and resulting glucose level, so that this dose of insulin gives me this level of sugar postprandial. And it helps in supporting and guiding decision-making with respect to meals, activity, and medication. Encourages the patients to become more involved in their own management, taking charge of their situation. And in respect to behavioral change, it provides more immediate access to glucose information instead of waiting for 3 months to get an HbA1c. Whenever I have patients who have the means to do self-monitoring of blood glucose, and this number is relatively small, it is probably less than, in the public hospitals, it will be less than 10% of patients. They will be able to ask questions within a very short time, like 1 week. In the private setting where the resources are available and the patient is able to share their readings with the healthcare provider, even 1 week's readings are enough for the patient to share with the provider and say, since I saw you last week, since you initiated insulin, this is my pattern. What do I do? And you're able to give guidance. If we wait for 3 months for them to come back, do a HbA1c, which was 10% last time, and now it is 9.8% after 3 months, you haven't made any progress, and you don't even know what you're going to tell the patient to do because it is blind, there's no reference. That is how frustrating it is, and when we are not able to afford this. In some developed economies of the world, all patients are issued with a glucose meter and strips and lancets as part of the diabetes package, and they are expected to, and they have a healthcare provider allocated to them who is able to communicate with them between this visit and the next visit. We do hope to reach there someday. So SMBG is clearly recommended by all care guidelines, as I have shown. Below, these are the same people. The difference here is that AADE is American Association for Diabetes Educators. There's a group of healthcare professionals that is still in a nascent stage in our country who play a pivotal role in diabetes care. The professionals who are able to educate our patients on various aspects of healthcare. We have in Kenyatta National Hospital diabetes educators that have helped us a lot in managing diabetes. Diabetes care is not a one-man show. It requires teamwork in order to handle. So these 3 bodies all recommend SMBG. So common patient barriers. Let's look at the barriers. I forgot to mention, I forgot to mention that much as it may appear like it's a straightforward matter, but achieving good sugar control is still a global challenge. I think the best controlled in countries where you think they have the best resources, less than half the people have their glucose on target. Why? Because we have multiple barriers. There are barriers to achievement of good control in those aspects I have mentioned. Poverty issues in our parts of the world, and then the challenges in our healthcare system, inadequate healthcare providers or inadequate knowledge, and then the issues of affordability of these gadgets, including the SMBG, the blood glucose testing kit. And you can see here that in one scenario, data may not be available. And you may have a patient who has a meter, but comes to the clinic and says, sorry, I forgot. And then we have seen situations where this is intentional because they've not done their best. And they don't want, they fear, they think there'll be a confrontation or there is embarrassment, and they do not bring. The patient may bring the meter, but not the logbook or graphs, where so in situations now, this is a higher level of care. And there are patients also without software, so they just bring you the meter, but haven't written anything, and maybe the memory is it has a 10 reading memory, and therefore it doesn't tell you much. And then you have a patient who tests infrequently, and therefore there isn't enough information. And you may not blame them for this. It may be an issue of cost and affordability. Or the patient says, I have no time. Or let me put it this way. It may be that the healthcare provider who is looking after 60 patients in a clinic in a county hospital has so many patients and has allocated 4 minutes to each patient, and there is no time. So the patient may not, the clinician, even if the patient has the the log and everything may not have enough time to look at this and discuss. You need a lot of time to talk about these things. Or you may have data that is haphazardly recorded and difficult to analyze, and difficult, a limited discussion of findings between patient and clinician. I've referred to that. And then uncertainty about moving from data to treatment choices, where there's a difficulty in really what to do next, and the cost factors, which are always there. So I wanted to show you this triad of a lack of patient SMBG impacting lack of clinician utilization, and in the middle, and also lack of clinician SMBG utilization may also, the patient may have the SMBG, but the clinician is not utilizing it. And the patient wonders why they've recorded all these things and the clinician is not even interested. And the bottom line is that there will be unrealized values. You will not achieve the target values. So structured self-monitoring of blood glucose and pattern management is the subject of our talk. And I think definitely Roche, Lily and team will be able to emphasize on this. This is what we have achieved in the modern era. A lot of development, a lot of innovation, a lot of tools available. The limitations are on our side. The industry that makes and innovates testing devices is doing its best. So structured testing stroke meaningful monitoring is like testing with a purpose. Why are you testing? And structured testing is testing with purpose or intent, or with an intent to understand. You want to utilize the parameters that you get. Structured testing is such that at the right frequency, at the right times, and in the right situations, done in that manner. It means it is not haphazard. It is pre-planned, the frequency of testing, the timing, and situations, especially with respect to means. And it is meant to provide information for better treatment decisions. And it begins with the patient and clinician agreeing on the following. So there has to be an agreement. As you issue a patient with a glucose meter, have an agreement. What target do we want to achieve for this patient? You have a 32-year-old patient and their HbA1c is 8.8. And then you have a 78-year-old grandmother and the HbA1c is 7.5. And these two people have different outlooks in life and different challenges. So you set a goal for each patient and you explain why. I have done that this afternoon. The 32-year-old I was talking about HbA1c of 8.8 and telling her she's completely off target. Why? Is because she will live long enough to have complications if we do not reach the target HbA1c. So you discuss when to test and how frequently. And talk about the values. In my earlier slides, we've talked about targets for fasting blood sugar, pre-meal blood sugar, post-meal blood sugar, and how to record and share the results. We are blessed that today we have the social media platforms. We have the various, the most popular of which being WhatsApp. It's helping a lot. You tell a patient, take a photo of your chart and send to me, and I will respond to you. And it actually reduces the need for telephone calls, which are tedious and less productive. But a message can answer a lot of questions, the patient. So this is an example of the impact of structured testing program or STEP study. The results of the STEP study, which demonstrated very clearly the difference between the impact that structured testing has. So the patients in the STG showed significantly greater improvement than the actual control group. The control group would be the group that did not have any structured testing, haphazard testing. And then STG physicians or structured testing group physicians initiated treatment significantly earlier and more aggressively than the control group physicians. So there was improved therapy optimization. As I have said, if you're able to get the patient's results sooner, every week, every 2 weeks, every month, this will allow you to plan intervention sooner than it would be the case if you have to wait for the next hemoglobin A1C. Both study groups saw a significant improvement in general well-being, and the STG required no additional SMBG. It is the effective and efficient use of the test strips, not wasting. This is an example of such, one focused SMBG protocol, where between Monday and in a whole week period, the patient and the provider agree to test in this manner. Remember, we said you reach an agreement with the patient and discuss the goal, and the patient goes to do what you've agreed. So the patient in this manner tests before all fasting blood sugar on Wednesday, Thursday, Friday, post-meal on the same day, pre-lunch, post-lunch, pre-supper, post-supper. This 3-day chart tested several times a day, structured manner, will carry very important information, will bear important information. So some of the typical applications for structured testing in type 2 diabetes is to help in decision of starting insulin therapy. It is applied before starting insulin, or already those who are receiving insulin. And if a patient is potentially at a high risk of hypoglycemic inducing oral antidiabetic drugs like the sulfonylureas, which are the main in most of our county hospitals. And even though the global utilization of sulfonylureas has dropped significantly, they have fallen down the pecking order, but we still use them because of cost, but they come with a big burden of hypoglycemia. And especially among the vulnerable groups, which are the elderly, people with renal diseases, and so forth. Very useful in newly diagnosed diabetics, in patients with A1C levels higher than the agreed target, and in patients who have hypoglycemic unawareness. We have a condition like that where the patient no longer senses when the blood sugar is dropping and dropping below 4, even to 3, to 2, and the patient has no warning symptoms. So structured testing will help in picking this population. And for women before planned pregnancy or during pregnancy, and for patients who are undergoing adjustments in their medication, nutrition, and physical activity. And for patients who are entering new life experiences, such as those who are starting new jobs, which jobs have certain challenges. What is required for successful pattern management? From the patient's perspective, the patient needs to have the skills to do the self-testing, understanding, ability to record, and understanding and correct recording of factors which may affect blood glucose, including stress, and to take action on the SMBG readings. And for successful long-term results, the ability to interpret blood glucose results and make adjustments accordingly. And for the healthcare professionals, what is required is the understanding between the link between glycemic control, glycemic variability, and diabetes complications, and confidence setting ranges to determine glycemic control, to be able to guide the patient in setting the ranges that are meaningful to that patient, an ability to interpret the results that will be provided, and skill to adjust the treatment and motivate and support the patients by explaining relationship between blood glucose value and the diabetes care. So there's a question here. What do you know what to do with these numbers? Can you see the patterns? So some patients, their book may look like this, full of numbers that are arranged, that are such that they're completely meaningless to the patient. Yet this is the important question. What's the meaning of the numbers that you have provided me with? So it calls for patience in order to explain to the patient what the numbers are that they have brought on the day of the clinic. So pattern management, a 4-step process to assess structured blood glucose management in a prioritized manner. Number 1 is to identify glycemic abnormalities by priority. The priority number 1 of all the diabetic abnormalities is hypoglycemia. We do not want people to have hypo. It happens, but it is undesirable. It is a barrier. It puts a barrier between you and the patient. The second priority is fasting, high blood sugar. And then the third priority is to deal with postprandial hyperglycemia. So these are the 3 things. Then point number 2 is to identify the time and frequency of abnormalities. An abnormality that occurs frequently, let's say 2 out of 3 days at the same time of the day, indicates a problem that needs to be addressed. This is the advantage of self-monitoring, because you will see a pattern. You will see there was a hypoglycemia on Monday morning, another hypo on Tuesday. Then on Wednesday, the sugar was normal. You worry about the 2 hypoglycemics and they are not due to chance. Now you can tell the patient, let's deal with this hypoglycemia. It is for you now to identify the cause. Is it the dose of the medicine taken in the evening? Does it require adjustment? Is it the meal size that has changed? Is it illness? Any of those things, you require a discussion with the patient. So investigate potential causes, as I've mentioned, including behavior-related relationship. Take appropriate action in terms of medication. I've mentioned that, and behavior. So provide instruction on medication administration. Provide education to refer to diabetes or diabetes educator for counseling or for appropriate behavior modification like diet, exercise, adherence to medication. I will skip this. Maybe I'll just show you what some of the readings look like. For this one patient, I just picked because of this chart. This is real for a particular patient here named Robert, or is it Harry? And you can see here, there's a blood sugar of 3.7, 11, and blah, blah, blah. The highest being 12.3, 12.7, and then the lowest being 3.7. And when you chart here, you can see a spike, and then other relatively stable readings until you have another spike, and so forth. Now, when you plot, you can see this range. This is where you want the patient's blood sugar to be, and yet you have a postprandial spike. This is 2 hours after breakfast. This is another 2 hours after breakfast. And then the hypoglycemic episode on this day was before breakfast. So these are some of the things you can discuss with a patient, day 1, day 2, day 3. Now this reading, this kind of chart is many times more useful than the single blood sugar reading. I would like to ask you colleagues, especially from the counties, to ask what goes on in the diabetes clinic in your area. How many blood sugar readings do the patients come with on average? Very sadly, it is 1, and it is the one done on the day of the clinic. It doesn't really help much. And then the patient who tells you, Daktari, my sugar is very, very good. I tested last Friday, it was 5.0. When you ask them, when did you test before that, they say, I tested also one in January and another one in February. And you know that you are not doing a good job. And maybe it may be that there is a reason that, and may not even be the patient's fault. Maybe they don't know. Maybe they can afford all these things, but they have not been properly instructed. As we come close to the end of my presentation, so the pattern management, an example, just one other patient here who is a type 2 diabetic, had come with a near normal HbA1c, started with metformin 1 gram BD, a high BMI of 29, exercises regularly, and recently became a vegetarian and eats a lot out in the restaurant, and normally checks his blood glucose when he feels unwell, and sometimes in the morning before breakfast. I think what is emphasized here is that this person is middle-aged, he's got what looks like a normal HbA1c, is on the correct prescription, he is overweight, close to obesity, he tries to exercise, eating out in the restaurant very frequently is probably not means that perhaps his diet management is not good. And look at his testing. He checks his blood sugar when he feels unwell, PRN. This is what we are referring to, and this is not structured testing. And sometimes in the morning before breakfast. So what has been emphasized here is that you cannot expect here, the clinician cannot make use of that information. So there has to be an agreement. I think these two people discussing are talking about focused SMBG in the manner that we have discussed. And my next slide, sorry about that. So, so additional comments on pattern management. I just chose this slide to show you some of the medicines that you dispense all the time. And hopefully they are there where you practice. And also, these are the agents with potential to impact fasting and preprandial blood glucose levels. So you can see many of the currently available medicines for diabetes care, which are exemplified by the biguanide, metformin, the TZD, where we have pioglitazone, gliclazide MR, and the newer group of SGLT2 inhibitors. These are available in good number of hospitals, but sadly not in many hospitals. The important thing here is that some of these drugs are very friendly in having low hypoglycemic risk. This is what the clinicians look at. What is the risk of hypoglycemia? Metformin ticks the box. Pioglitazone ticks the box. The SGLT2 inhibitors ticks the box. And then the insulins, all insulins are potential causes of hypoglycemia. And weight is another factor that is of importance in choice of medication. Most patients would want their weight not to go up because of medication. Yet, sulfonylureas, which have not even been put on this list yet, they're actually the bigger proportion of medicines in our public hospitals. Then sulfonylureas are not weight neutral. Only metformin is weight neutral. Pioglitazone and gliclazide MR, you gain weight because this is a sulfonylurea. Then the new group, SGLT2s, is actually among at the moment, one of the only drugs that is associated with any weight loss whatsoever, which is very, very important even in patients who need to manage their weight. And low, so you see this one, low risk of hypo or no risk, and weight loss. Perfect. This drug is very important. If the patient fits the profile for it, if the drug is available, if the HbA1c and other factors favor the prescription. These are some of the things we try to do. We are doing this kind of thing. We are trying to do that in Kenyatta. Even as we review the hospital formulary round, we are trying to look at which drugs are going to serve our patients best. So the insulins are important, but you can see the hazards. High risk for hypoglycemia, high risk for weight gain. These patients are very unhappy with any drug which causes weight gain in this day and age. except the patient who had lost so much weight, they become so thin, and their weight begins to come back on initiation of insulin. That's the only patient who will be happy with you, but the rest are not happy to gain weight on therapy. Again, another group of medicines I'm not going to overemphasize. This is another list consisting of the various oral agents, various insulin. What I'm talking about is that the potential for hypoglycemia, potential for weight gain, weight loss, or weight neutrality, those are the factors that we consider. So structured testing and pattern testing, I think, is what our topic has been. The various tools. This is this is the logbook. This is testing in pairs, and this is your laptop or computer to draw the graphs and be able to share with the clinical team. So in summary, colleagues, managing diabetes requires meaningful, readily available data about daily blood glucose levels. HbA1c testing alone does not provide the complete picture. That cannot be overemphasized. It's important, but not enough. Structured testing is very important and enables the patient to obtain meaningful information. And there are a number of ways structured testing can be advised depending on the patient. And shared discussions of findings can help improve therapy decisions, patient engagement, and may make time in clinic more effective. The patient will feel that I've had a meaningful discussion with my clinician today. The four-step testing pattern, or the four-step pattern management process, not only saves time, but also facilitates more robust and productive patient-clinician interactions. Through this improved dialogue, patients may easily understand the relationship between their behaviors, metabolic responses. In addition, therapy decisions are more easily understood and adopted. And also, this can lead to greater motivation and ultimately better clinical outcomes, which is really the bottom line. Better outcomes, quality of life, survival. So, structured testing is doing now what patients need next. And ladies and gentlemen, that is the end of my talk. And I thank you for listening to me. And that's the end of my presentation. Thank you very much.
Thank you. Thank you, Dr. Thank you, Dr. for that informative presentation. I can see a lot of community pharmacists celebrating that. I think they relate well, frequent monitoring. I want to make a quick transition from you, Dr. Meanwhile, you can go through the questions that may have come up and see the direction of what people want to know. We'll handle the question and answer after Lily's presentation. Lily, I'm inviting you now to share your screen. Yeah, then take us through your presentation. We'll have short and answer question after your presentation. Karibu, Lily.
So thank you so much, Dr. Eric, and to the whole PSK fraternity. Good evening, panelists and members of the PSK. My name is Lily Wanjiko. I work for Roche as the market manager for Roche Diabetes Care. If you can see my screen, please let me know.
Yes, it is visible.
Great. So thank you, Dr. Sigilai, for the informative talk around self-monitoring of blood glucose and, of course, diabetes at large. As we've seen that diabetes is quite a global epidemic, and the numbers are getting higher by day. But then in terms of diabetes management, the important thing that we are bringing in is the aspect of one of the legs of diabetes management, which is self-monitoring of blood glucose. So you can't talk about diabetes without talking about blood glucose control, because it sits really at the heart of diabetes, because when a patient is monitoring, they're able to understand how different things that they are using are affecting their sugar. So I'll quickly go through our products, which may be familiar to most of you, but probably not familiar to everyone, just to understand what Roche brings in terms of diabetes management for our patients. So I'll start with AccuCheck Instant and my sugar. So AccuCheck Instant is a system we call the effortless choice, and that's how it looks. It comes with a lancing device and strips, and it has a pairing button right there you can see that shows something like a Wi-Fi, and I'll tell you what that is as we proceed. So it comes in with a big bold result in a backlit display. We know that most of our diabetic patients have challenges in terms of their eyes, in terms of vision. So we make it our business to bring in a product that is very, very clear so that the patient is able to visualize their blood glucose reading. It comes just with one button to make it very easy to navigate for the patient, and the patient is actually even able to see the last result on the meter. It comes with averages, and the patient is able to see a 7-day average, a 30-day average, and a 90-day average. So a patient can essentially look at an AIC with our meter. So they're able to see how their sugar control has been for the last 3 months. So AccuCheck Instant comes with instant clarity with 9-point scale, customizable for the patient, or what we call the target range indicator. So when we developed this meter, we looked at a Carascope where patients were able to quickly identify their sugar and make sense. So basically, most patients could not make sense of the numbers. And Roche went and developed a meter that patients would actually quickly see where they are and take action. So basically, the red denotes low because we've been told by Dr. Sigilai, we don't want our patients to get into hypoglycemia, and red really denotes danger for us. So when the reading blinks on the red dots, the patient knows that their sugar is low and they're able to take quick intervention, probably take a snack or take some glucose or something sweet to bring their sugar to range. Green means we are within range, we are doing well and things are good. And blue means we are above range. So when a patient is able to see at a glance from a color code that your sugar is constantly high, they're able to make interventions, probably go see the doctor, probably start exercising, probably change their diet so that they bring their sugar to the range, and the range is usually between the green part or where the green dots lie. So this study that was done when we developed the AccuCheck Instant with the color coding, basically 94% of the participants said they were confident about interpreting their glucose levels when they were able to visualize. 80% of the participants said they were able to make correct dosage decisions when they saw the color code. And 87% of them said they would actually switch a meter to a meter that has a color code so that they're able to make quick decisions in terms of diabetes management. So the AccuCheck Instant system comes with a very unique strip. And the uniqueness of our strip is that the performance is excellent. The test time is less than 4 seconds. So a patient probably having a hypoglycemia, and we are wondering how the sugar is, within less than 4 seconds, we can actually get a glucose reading. Actually, the reading speed for the AccuCheck Instant meter is actually 3.75 seconds. This meter takes the most least blood. So our meter takes a sample size of 0.6 microliters. And you can actually check different blood samples where you can actually check capillary blood, you can check venous, arterial, and neonatal. And with this meter, you can also use alternate testing sites where you can use your forearm, or your upper arm to actually check different glucose. So in terms of the strip also, if you look at the size of the strip, we actually say that it has the widest dosing area. So if you look at the yellow part, the patient can actually dose or can actually apply blood from any area of the yellow part, whether it's the lower side or the sides. So it's easy and it feels very, very fast. And within less than 4 seconds, the patient is actually able to see their glucose reading. But the one thing that is very, very unique with our product is the accuracy. And Dr. Sigilai will really concur here that a meter that is accurate really helps the doctors make accurate therapeutic decisions, because the doctors depend on the glucose readings to either start the patient on insulin, to actually start the patient on other forms of treatment. And with an accurate meter, and we know that the meters that we have, not all of them have met the ISO criteria of accuracy and precision. With an accurate meter, we are very confident that whatever we are actually prescribing is actually going to help the patient, and the patient may not end up getting hypoglycemia or undiagnosed hyperglycemia. So the AccuCheck Instant meets the 10-10 accuracy, which is an even a tighter criteria. We know, according to the lab requirements, is that all blood glucose levels should fall in within either 15%, any sugar above 5.5 or less than 5.5 millimoles. So basically what we say, if you want to know the accuracy of a meter, don't compare glucose readings with 2 meters. We've had people call us from pharmacies saying that, the patient came, there's a variability in terms of glucose, the patient tested with meter A and versus meter B, and we are not sure. So basically what we say, if you want to know the accuracy of a meter, use an independent lab method to actually verify, because different meters use different enzymes. So in terms of our advanced accuracy, like I've mentioned, basically what we use a lab referencing method. And what the ISO criteria actually means is that all readings must fall within 15% of the lab value. So any sugar above 5.5, for instance, should fall within that range. But because the AccuCheck Instant even meets a tighter criteria of a 10-10 accuracy, it gives a 10% variance, which is actually 0.56%. So basically, it's even a more tighter control in terms of accuracy, and it gives a better variance in terms of how accurate this meter is. So the same thing applies to any glucose level less than 5.5. It should fall within that range. And like I've mentioned, according to ISO, the range should be anything between 15%, but with the AccuCheck Instant Meter, it gives us a range of 10%, which is actually just a variance of 0.5%, 0.56 millimoles per liter, making it very, very accurate. So that's the AccuCheck Instant. This is the study that was done with the PACS consensus error grid. And what you can see is that the consensus error grid between levels A and B, the glucose readings were supposed to sit in between the area around A and B. But according to the study that was done, the AccuCheck Instant, the readings actually all fell within level A, making it very, very accurate, and a meter that you can actually recommend with confidence that the glucose level you'll find is actually very, very accurate. So in terms of the lancing device, as we all know, a meter comes with a lancing device, or what we call a pen by most people. So basically, this is the one that the patient gets a blood sample with. This is the one they use for pricking. So basically, we have a patented technology, which we call the Clicks motion. But one thing about our lancing device is that it's really trusted, it's comfortable, and it's virtually pain-free. Like I've mentioned, it comes with a patented technology called the virtually pain-free technology. So basically, when we talk instant, we say that effortless starts here. So basically, the patient can download data with a computer, because the meter comes in with a USB port, and they're able to see graphs, and the doctor is now able to make quick therapeutic decisions when they're able to see data at the comfort of their office on a PC. And this really saves time to the doctor, And the readings are self-explanatory. So the patient and the doctor are able to get very good conversations around where are we getting lows, where are your sugars going high, what could be happening here, and they actually make better decisions in terms of managing the patient. So in terms of the AcuCheck Instant, it's basically really ideal for all patients with diabetes, whether newly diagnosed, whether they are on insulin, whether they are just on exercise. It comes with a clarity with the target range indicator, and it's more comfortable with minimal functions. But the other beauty about the AcuCheck Instant is that, like I told you, it is Bluetooth enabled. So this meter can actually pair with your smartphone. So basically, you'll just go to Google Play Store or App Store, depending with whether you're using Android or iOS platform, and quickly download My Sugar app. So My Sugar pairs with the AcuCheck Instant meter. So if you look at the back of this meter, it comes in with a code that once you pair, it actually asks you to input the code, and then you're able to download the glucose readings quickly to your phone. These results can be paired, can be shared with the doctor on a PDF, and the doctor is able to communicate with the patient much faster. So for instance, a patient has just been diagnosed, came in, probably started on insulin, or has just been discharged home, and the doctor wants to see how they're doing, maybe for a month or for the first 2 weeks, just to see how they're responding. So they'll just need to use an AcuCheck Instant meter. They download the app, and then they're able to share this data with their doctor. So basically, it's an app that's being used by over 2 million people around the world. And the hashtag is that we say that we make diabetes suck less. So basically, how it comes in, it looks at personalized diabetes management. That's where My Sugar fits in, because it's looking at self-monitoring and decision support. And the study that was done around personalized diabetes management showed that it lowers HbA1c by 0.5%, because quicker decisions are made. The patient is more engaged in managing diabetes. They are able to take decisions because they are able to see quickly what is happening. And this eventually helps lower A1C. So at a glance, My Sugar looks like that. For those who probably have it on their phones, or those who are downloading, what is actually available is that you're able to see immediately numbers, graphs, and trends of the patient. You'll see a HbA1c estimate. Of course, there's motivation where the app brings in around information around how to motivate, endpoints, stuff like that. And then it even has an option of input where the patient can put in meals, medication, sugars. They are actually captured quickly and easily. So in terms of the pages, you can see the different interface pages that are available once the patient is using the My Sugar app. And yeah, you are actually even able to see more in terms of their notes, their photo functions, challenges you're able to key in. And the patient is actually able to play around with these things and make and have fun with the app. So in terms of the reports, we can actually see different reports. We can see the monthly statistics, quarterly statistics, depending with what you want. You can email, you can send via PDF, depending with your preference or what the doctor really wants to look at. If it's a child who is at school and a parent wants to see how they are behaving or how their sugar is behaving, this can actually come in very handy, and they're able to share this data even at home. So basically, when we talk about AcuCheck Instant, we say it's effortless by itself. Just to give you a summary in terms of what effortless means, it means that we are bringing in a meter that you don't need to set up. You just need to apply a small amount of blood, and within less than 4 seconds, you get a reading. You're able actually to share or pair your meter with your smartphone through My Sugar app, and you're able to see data. So the data just quickly moves through Bluetooth connectivity to your phone, and you're able to see the data of your glucose reading. Over and above that, we bring in a lancing device that is really comfortable and that is actually virtually pain-free. So remember, one of the barriers to self-monitoring of blood glucose is actually pain. So patients say we don't test because testing is painful. So we are bringing a meter with a lancing device that is actually virtually pain-free. So I'll take you through now our other products, which is the AccuCheck Active. I'm sure most of you are familiar with AccuCheck Active. AccuCheck Active has been there longer. As you know, the instant that I've just talked about, we launched it like two years back, but Active has been there longer. So I'll take you through Active quickly so that you also know what else we are offering to the patients who have diabetes. And then when you have the two products on shelf, you're able to decide which one you give to what patient. So AccuCheck Active has been there long enough. We've had several generations of AccuCheck. We have the first, the second, the third, the fourth, and the fifth. So just to let you know that the AccuCheck Active system has been there for more than 40 years. But basically, we started developing different generations in 2001. And then up to 2016, when we brought in the new AccuCheck Active with no coding. So for those who have been there, although those who are probably very familiar with AccuCheck Active, initially we used to have a coded meter, but now the meter we have requires no coding. So basically how it looks like that. It has a two-shell design with a large display, like what we talked about in terms of display. It has two buttons just for the setting, the memory, and it has what we call a flexible in-out of meter dosing for glucose testing. And it has the test strip guide where you actually insert the strip. It has a beep tone. The moment you insert a strip, the meter goes on, and it comes with a preset date and time. So you can never lose data, irrespective of whether you remove the battery or not. The other thing is that it comes with a visual double check. So basically what there is that with a strip of AccuCheck Active, and I'll show you in a later slide, you can actually perform a test if the meter has a low battery, and you're able to compare and get a range of the glucose over and without using the meter. This meter comes with what we call clever functionality. That means you can actually flag glucose readings. You can put the pre and post meal marks to differentiate levels of blood glucose before and after a meal. So let's say you want to test a sugar before breakfast, you can actually flag it so that you put a sign around it. So basically the symbols that come in are a full apple to show that that was before a meal. Then you can actually put an eaten apple to show that that was 2 hours after a meal. And you can actually get the different test averages, just like our instant meter for 7 days, 14 days, 30 days, and 90 days. This meter comes with also a USB interface for data transfer. So with AccuCheck Active, how we transfer data, we use a software called the SmartPit software. So this is the one that is actually downloaded on a doctor's personal computer, and the patient just needs to bring the meter, and the doctor downloads the results just using a normal USB cable like the one used for charging the phone, and they're able to see data in form of a graph, and the doctor is able to make quick therapeutic decisions because they are able to see what is happening and understand the variability of blood glucose. Over and above that, it comes with 500 test results with date and time. Very, very important, all our meters have met the ISO criteria of accuracy and precision. AccuCheck Active has met the ISO 15197-213 ISO requirement, and it actually got 100% in terms of the percentage. So like I've told you, that's how it looks like. The strip looks like that. Just to show you in terms of transferring data, the meter comes with an USB port. You can see the part labeled 1. So that is where you actually plug in the USB cable, and data is actually transferred to a computer. once the doctor has the Accucheck SmartPix software. Like I told you, with this meter, you can actually do a visual backup. So basically, you can put blood on the strip, turn the strip, and compare on the container and see a range of glucose. So this can be done, let's say, when the patient has come in and they have collapsed, or in a situation where the battery has run out, you can actually do a visual backup with the Accucheck Active Meter. The lancing device comes in with pain-free lancing with clicks motion. So clicks motion helps the strip, the lancet go in and out. So most of the lancing devices we have in the market, what happens is that they go in a spiral motion. That causes a lot of trauma to the tissue. But with the Accucheck soft clicks, it goes in and out. So that reduces trauma to the skin and makes it virtually pain-free. So basically, this is the clicks motion explained. So what you can see here, it has a three-sided lancet cut, which goes in and out. Most of the other conventional technologies uses the spiral method, and this causes a lot of vibration, causes a lot of pain to the patient. Yes, and it's easy, very simple, precise lancet movement. It's practically very silent, and you can actually adjust different depth depending with the patient's skin. So remember, some patients have soft skins, others have a bit tough skins. So depending with the skin of the patient, you can actually adjust different lancet depths. And that's about it, about our products. Thank you.
Thank you, Lillian, for the presentation. I don't want to waste any more time. I promised not a minute past 8:30, but we have questions. And I'm grouping these questions into three. As you take a breather, Daktari, Lillian, I want Daktari to answer two questions combined. Then we'll come back to you because the other group of questions relates to the device, the costing, and how it can be more available at the community pharmacies. So Dr. Sigilai, I've seen there's one question that you've answered live and another you want to answer live. One you've answered already, but I would want also for the benefit of the others, they hear the answer. So it relates to fasting and blood glucose, blood sugar. Question is morning fasting blood sugar monitoring better compared to morning random blood sugar monitoring? So I invite you to answer that. And while you're answering that, you can make mention of the question that you already answered. How do you manage diabetic patient who is fasting? Because this is the month of the Ramadan, of course, and the blood glucose is not well controlled. So Dr. I invite you to answer those.
Thank you, Eric. With respect to the first question, fasting and versus random, fasting is a definitely useful blood test. If you look at the recommendations of the three international bodies, ADA, IDF, AACE, the three recommended blood glucose tests for the purpose of monitoring blood sugar is 1, fasting, 2 is 2 hours postprandial, and 3 is hemoglobin A1C. Now, the so-called random blood sugar is actually unnecessary. It is completely random, as the name suggests, because it has no utility. And I know patients walk into chemists. Some of our colleagues here run chemists, and they say, I want to do a blood sugar. Now, remember, Lily has just talked about structured testing, and I also talked about structured testing. What is the value of that single test? Even as you do that test for the patient, please remind them that a single test may not help the doctor whatsoever, will not help the patient whatsoever. if they have to, because of factors beyond their control, including poverty, if they must do a test, let it be a fasting blood sugar, not random. The random should be because there is a reason to test. For example, if a patient really is worried about things like hypoglycemia or the way they are feeling at that moment, that's the only time the random may give some information. But habitually testing randomly is of no utility whatsoever. So emphasize fasting blood sugar. With respect to Ramadan and testing is a good question. We answer that question every year, and these topics come up all the time, even among the physicians. And the question, I know I typed an answer, is a long answer, but the best way to begin is that it really depends on the patient characteristics. Let me start by saying that not all diabetic patients, diabetic Muslim patients will be able to fast. Take, for example, a type 1 patient who is on 4 injections of insulin per day. And you can't inject and fail to eat. And you cannot skip the insulin because you'll end up in trouble. So let me start by saying perhaps hardly any type 1 can fast because they're always on multiple insulin injection. The people who are on hypoglycemia-inducing medicines will have a problem. I've mentioned sulfonylureas as being notorious for causing hypoglycemia. The other group of medicines that cause hypoglycemia are insulin, the older versions of insulin. And the one that you have in most of our pharmacies, Mixtard, is a combination of 2 long-acting insulins, notorious for causing hypoglycemia. So if your patient is on Mixtard, BD, and they want to fast, they will inject at 5 a.m. and one of the insulins reaches its peak level between midday and 2 p.m. and they get a hypoglycemia. And you're fasting and you're not supposed to eat. So in short, the people are more likely to fast and have no problem. One, those who have started off with very good hemoglobin A1C to start with, which we said has to be below 7%. 2, the patients who are on once a day medications that do not cause hypoglycemia, which include the DPP-4 inhibitors and the SGLT2 inhibitors, and probably those who are on once a day insulin, like the basal insulin, glargine, glulisine, Ditema. Those can have one dose and then no risk of hypoglycemia until the next until they unfast. Thank you. Eric?
Thank you, Daktari, for the answer. I think they are well captured. The other group of question relates to you, Lily. I'm sure you've seen. It's a question of, there's one interesting one that is asking, the strips compatible with other glucometers? That is one. Then you can mention about cost, because it seems to be the barrier it seems to be the barrier for the population to access and talk about cost in short. Thank you.
So thank you, Eric. So in terms of compatibility, basically what happens is that if you're using AccuCheck Instant, you use it with AccuCheck Instant strips. If you're using AccuCheck Active, you use with AccuCheck Active strips. So basically the meter carries its own strips. It's not compatible to the other ones. So I hope I've answered that question. The other question is around costs. And I want to make it very clear here because I think there's a lot of misunderstanding or myths around Roche and the AccuCheck blood glucose meter in terms of pricing. We've really looked in terms of access and making sure that our patients and our population around this part of the world are able to access a glucose meter and strips, and they're able to test quickly. So basically our strips go for $14.50. That is for the active, for a pack of 50. and 15.50 for instant, for a pack of 50. And basically what happens in a pharmacy scenario is that every time you buy maybe a pack, you get a meter free. So basically, if you get in touch with us or our distributor, you're able to get the privilege of finding those benefits. And just for the sake of making it clear, we have 2 distributors currently. We have the Sagifarm and we also have ScienceCo. So if you reach out to our distributors, they're able to extend that price to you. And actually, you can get even bonus meters. So yes.
Thank you, Lily. We were late with 10 minutes. I don't want us to be late when we end. Daktari, I have one question for you from Dr. Arti Kamau, who is asking, comment on vitamin C and zinc supplementation on managing blood sugar. I believe this is because these are some of the commodities we are using for COVID. Is there any advantage when you use zinc or vitamin C?
Thank you for the question. As far as I'm concerned, there is no benefit whatsoever, especially with respect to vitamin C. I think there have been reports now, studies that have come out in the last couple of weeks and months that have disproved the notion that vitamin C is useful. I know we've sold in tons. There are many drugs now that have been sold in incredible quantities because of the and trying to do anything possible to prevent. And the answer is that there isn't. Zinc either is not proven either to play a major role in blood glucose control. The standard approach to blood sugar control is 3-pronged. That is appropriate medication therapy, appropriate medical nutrition therapy, exercise, and or weight loss. Those are the 3 cornerstones of diabetes management. And then a good support system to enable the patient to have ongoing care, ongoing review over the years in the manner that we have discussed, to enable the patient to be able to access information and to be able to have a conversation with the healthcare provider for intervention with respect to the trajectory of their blood sugar control. Thank you.
Thank you, Daktari. I feel we are missing so much of your resource because of time. Hopefully we can get another opportunity. One last one, Lily. What is the lifespan of the meters? Quick question. Without thinking.
Yeah, so our meter, we actually say has a lifetime warranty, but basically what we see is that probably after 10 years, because of use, sometimes people drop, they probably change the meter, but it has a lifetime warranty, but basically within 10 years, you probably may need to change. The beauty is when you bring an old AccuCheck meter, we will always change it for you for free through our distributors. Yes.
Good answer. Thank you so much. I would like to bring it to a close. It was quite informative. Daktari, I still think there's so much you could have learned, but we didn't because of time. Thank you all attendees, pharmacists, members for attending. Remember to subscribe. And up to that point, I would like to invite Mbao to close the meeting. How kindly.
Asante, Dr. Eric Murengu. Thank you very much, Dr. Sigilai, for the wonderful presentation. I have sat on my desk all through going through it. And also, Lily, thank you very much for taking your time to even recommend the best speaker for this webinar, Dr. Sigilai. Thank you very much, and thank you very much for agreeing to sponsor us. So probably from our members who are here, Lily, some of them are asking me, I know they're asking, wanauliza kimoyo moyo, could we be probably having another webinar from Roche Diabetes? We're in the month of May. Probably let's have another one in the month of July. Allow them probably to look for the AccuCheck with the distributors in the month of May, June. Then after that, July, you bring them something else that Daktari is going to be able to guide them. They just want Daktari so that they interact with him fully. Thank you very much, Lily. Also to you, Dr. Eric, asante sana. To our senior members who have joined us, I can see none other than Dr. Titus Kahiga, Dr. Wellington Muirore, Dr. Tom Sindani from Western Branch. Asanteni sana. Lililo na budi, lililo na mwanzo lazima liwe na mwisho, na mpanda ngazi lazima ashuke. Tumefika tamati ya usiku wetu wa leo. Sina lingine ile kuaga na kuambia alamsiki.
Thank you and good night.